Thank you very much for the invitation. It's a great pleasure for me to present our experience here at the University in Dresden with regard to the use of convalescent plasma. Convalescent plasma is used here in our hospital in Dresden on compassionate use. On the first slide, you see here Dresden, which is a city in the former east part of Germany. It's 1 hour south of Berlin and about 1 hour north of Prague. It's a very historic city, but of course has lots of modern technologies available at especially in bioscience and in medicine. The question first is, what is convalescent plasma? And convalescent plasma is derived from a patient, in this case of COVID-19, a patient who has undergone an infection and has recovered from the infection. He usually builds antibodies in the plasma, which can be found in the plasma. And if you collect then the plasma by, for example, plasmapheresis, this plasmapheresis will contain not only antibodies against SARS-CoV-2, but ideally neutralizing antibodies. And these neutralizing antibodies can be infused into a patient. And in the case that the patient is suffering from COVID-19, this would be like a acute therapy. But on the other hand, one could also theoretically think of giving it to people who are exposed to have higher exposure risk for COVID-19, so that you could theoretically give it in a preventive measure. So first you need an immune reaction in an ill patient, induction of neutralizing antibodies in the patient, then the collection of the neutralizing antibodies by plasma collection, and then infusion into a patient, or theoretically also as prophylaxis. With regard to COVID-19, the humoral immune responses after infection has been observed for other viral infections which have some same background like COVID-19, for example, SARS-CoV-1, but also MERS-CoV. There it has already been reported anecdotally that the transfusion of convalescent plasma containing neutralizing capacity has shown some therapeutic benefit in these patients. The experience was that convalescent plasma is safe and that it is feasible, and efficacy, it was shown that it has advantages reported regarding survival, length of ventilation, length of stay in an ICU or in the hospital. But for those infectious diseases, there has never been done any randomized controlled trial. So the evidence is only a retrospective analysis from these former infections. There has been reported in 2015 a report which summarized the experiences from the other viruses for convalescent plasma. And as you can see, odds ratio, if it is 1, everything which is on the left-hand side would show a protective effect for convalescent plasma. Everything which is on the right-hand side is the more harmful effect, or at least no beneficial effect. And if the standard deviations are crossing the odds ratio of 1, then it is not significant. And what we see in the overall for all these trials is that there is a tendency for a better therapeutic and protective effect for convalescent plasma in the above mentioned viral infections, but it is not significant, and there is overall a big variability. But nevertheless, especially in the absence of other possibilities in Germany, we very early addressed these questions, and we formed a big consortium in Germany which comprised 18 German hospital centers. And the task which was taken here by Professor Schreetzemeyer from Ulm and Seifried from Frankfurt was to establish a clinical trial, randomized, prospective multicenter and open-label clinical trial for convalescent plasma compared to the best supportive care for the treatment of patients with severe COVID-19. This clinical trial was initiated last year in spring in 2020. The trial has the acronym CAPSID, and it has 53 patients per treatment group. So in total, 106 patients, and it has an anticipated drop-off rate of 10%. The convalescent plasma dose in this group is comprising of 3 treatments, each 250 to 325 ml of plasma. And usually they are coming from one plasma donation. You can harvest as much plasma from one donation so that you are able to have these 3 bags of a minimum of 250 ml. And so from one donor, 3 bags are given to patient and should be transfused on day 1, day 3, and day 5. And the study duration was anticipated with 1 year. This clinical trial, CAPSID, as I already said, enrolled, was comprising several centers. Some centers were only plasmapheresis collection centers in red. Others were only sites for clinical trial. All university hospitals scattered throughout Germany here. And some centers like Dresden, which you see here on the right-hand side, is where I report from now. We were collection site and also clinical trial site for this CAPSID trial. The enrollment of patients had been completed as of January 21st in 2021, so this year. But the results are still pending, so we don't know yet if this CAPSID trial in fact showed a benefit for patients with COVID-19 for the transfusion of convalescent plasma. But there's other trials which had been published. For example, here, this trial by Salazar et al. And they looked into Kaplan-Meier curves for, as you see in A, the overall mortality, in B also, on the x-axis or y-axis always the overall mortality. And you see that over all patients, the mortality in those who did not receive convalescent plasma was 7.6%, and in those who were transfused with convalescent plasma, it was only 3.7%. And what they found and reported was, if you look now into D, these are the patients which profited best, and you see the difference again, 7% overall mortality in not transfused patient, but only 1.2% mortality in those patients which were transfused within 72 hours of admission to the hospital with plasma that had a very high defined IgG titer against SARS-CoV-2 antibodies. And so since they in their publication here could indicate that the time point and transfusion is critical, it might be necessary to, in a very early phase, infuse the convalescent plasma as compared to late stage. In C, you see secondary matched patients transfused later than 72 hours after admission, and you see that there is hardly any difference in the outcome between both groups, convalescent plasma and the control group. What is a little bit striking here is that in this case, the outcome of those patients was also much worse for those patients who were not transfused, 11 point compared to 7 point here. How this came together, I don't know in this trial actually, but it's a little bit keeps one wondering how this comes. There's other indications who recent publications from this year, 2001 New England Journal of Medicine, and they suggested that the early high titer plasma therapy prevents severe COVID-19 in older patients. What you see here is the patient group. It was a randomized clinical trial. The incidence of patients with severe respiratory disease was 25 patients among 80 overall patients, which corresponds to 31%. And you can see those recipients of donor plasma with a high titer, which was above the concentration, the prevalence of patients with severe respiratory disease, it dropped to 3 out of 36 patients, which corresponds to 8%. And those which had only low antibody titer in the plasma, they have a prevalence here 9 out of 42 patients with severe respiratory disease. So this translates to the relative risk. Of course, in the placebo group, the risk was set to 1. And then you could see that there is a relative reduction in the risk for those who received high titer convalescent plasma to 30%. And even in those which received a low plasma titer, plasma with a low antibody titer had a relative risk reduction of 31%. And what is shown here on the right-hand side is the antibody concentration in the serum of the patient after infusion. And you could see that it is, of course, significantly increased in those patients which had received convalescent plasma. There is another report also from this year. It's a brief report from Hueso et al. In the Journal of Blood, and they have analyzed if convalescent plasma therapy has a benefit for B-cell depleted patients with protracted COVID-19. So these patients are severely immunocompromised. They have B-cell depletion with rituximab due to malignant B-cell lymphomas or leukemias. And in these patients, they reported that COVID-19 disease takes very long time. They have also viremia of the virus. And due to the lack of B lymphocytes, these patients are not able to fight the SARS-CoV-2 infection. And in these patients, they have been using convalescent plasma. And what they have been able to observe that it, as a proof of concept, that the COVID-19 convalescent plasma represents an interesting approach in B-cell depleted patients with protracted COVID-19. And COVID-19 convalescent plasma induces a decrease in temperature and inflammatory parameters within 1 week after infusion. And it is also associated with a weaning of the oxygen supply. So the entire situation for the patients significantly improved after infusion of convalescent plasma. So what we can see is that there is many trials, and there is many trials also which have already shown that there is no benefit by convalescent plasma. And here I have put you up a pre-publication now online for March 9th this year. It's the recovery trial from Great Britain. And I think this clinical trial is really very meaningful because it was a randomized controlled trial and they have significant number of patients included. They have included patients who receive convalescent plasma, as many as 5,795 patients. And the usual standard care without convalescent plasma was 5,763 patients. So a very big group of patients. And the primary outcome was mortality rate at 28 days. And interestingly, we observe that there is no difference in the mortality rate between those who received convalescent plasma with 24% and those who received standard of care, which was also 24%. If we look for the secondary endpoints, which was duration of hospitalization, days of discharge from hospital within 28 days, or invasive mechanical ventilation or death, invasive ventilation and death here single also. So the combination or all these parameters single, we observe that there is no difference whatsoever for any of these secondary outcomes of this randomized clinical trial with so many patients. And even if we look in the subsidiary outcomes, we don't see any significant difference. So if it was only for this huge, big clinical trial, one has to admit that the convalescent plasma is not associated with any benefit to the patients treated with this, no benefit at all with regard to primary and secondary endpoints, also not in subgroups. Now, we started in Germany last April to produce convalescent plasma. It was very much driven by all these media and news and horrible scenes which were coming over from Italy at that time point, where they had the triage and no medication was available. And at that time, already the Paul-Ehrlich Institute, our competent authority, said that the convalescent plasma should only be used in the context of clinical trials under controlled conditions, so to say. But with the capsid trial, which was put up, as you saw, it was only 56 patients per group, which could be included. And all hospitals in Germany have been making lots of pressure because they said, we need this convalescent plasma and it has to be made available. Because there was no other treatment available at that time, and the doctors felt only comfortable with convalescent plasma as one alternative. And the Paul-Ehrlich Institute was sticking with its position that it only has to be done in the clinical trials. But the federal state authorities of the different regions of Germany, like Bavaria is one region and federal state, and then we have North Rhine-Westphalia and many others. They basically were able to allow the use, the production, manufacture, and use of convalescent plasma under an emergency marketing authorization. And this was what was made possible in April in 2020. Basically, also after in United States, very suddenly, convalescent plasma was made available under an emergency marketing authorization for the United States. And then the pressure in Germany was so big that suddenly everybody started with convalescent plasma. And this is just the IND status for the capsid trial, which I introduced. It started in April 8, 2020. And because not all could participate in this trial, it was possible to produce it also locally for the to provide the plasma in the university hospital. So that's what when we started to do this in parallel at the university hospital in Dresden. And here you see a little bit how we did this. It was a collaboration between the university hospital and the German Red Cross Blood Donation Service. First, what we did was that the university hospital was screening all patients who were who were hospitalized and released from hospital 4 weeks after they have become symptom-free. They were screened for medical history, and then blood was collected, and then our institution was looking for the antibody concentration in this blood. And so we were able to screen several hundred donors to only find like a handful of donors which had very high antibody titers against SARS-CoV-2 and also neutralizing antibodies, which was very important to set up a pool of donors for the plasma donation. And only after those donors, at that time, we also did the several PCR tests from the swab to make sure that no infectious person is coming into the blood donation service. So those who qualified were negative by a swab testing for PCR and who had high titer antibodies, they were then eligible for coming into the blood donor service for the first eligibility examination. We looked into many things. The questionnaire informed consent, of course. We repeated SARS-CoV-2 PCR. We also had a SARS-CoV-2 PCR from the blood, which probably today is not necessary. Not necessary. We had infectious disease marker testing, which had to be negative. Antibody determination again, and especially with regard to female donors who have a history of pregnancies, they can make antibodies against HLA or other granulocyte antigens, and they are then, if they are transfused to patients, they make something which is called TRALI, transfusion-related acute lung injury. And of course, we wanted to exclude that these side effects are may occur after transfusion of convalescent plasma. And also what we did, but it was not a release criteria, in parallel, we determined the neutralizing antibody capacity, which was done at the virology department at the University in Berlin in the laboratory of Christian Torsten. And they analyzed in a live virus assay how many antibodies are contained in the plasma with real neutralizing capacity. So if this all was done and the infectious disease marker testing was negative for HIV, HPV, HCV, etc., we would then start with the collection. One plasmapheresis donation would comprise 700 ml, and we would then process this bag of plasma further, in our case, by pathogen inactivation. The pathogen inactivation is a process where the plasma is incubated with a photo-inactivating substance such as psoralen. There's several other ones, and then it is submitted to UV light, and this combination then destroys DNA double bands and everything which contains DNA, like DNA-based viruses, also bacteria, will be destroyed, whereas the plasma components and the antibodies are stable, and so you end up having a very safe plasma product. And this is how it later looked like then. It's 3 bags, 200 ml each, labeled as COVID-19 plasma, and provided then on compassionate use to the patients in our regions. What we were very keen to look at, because we introduced this pathogen inactivation, the early reports from Chinese groups also employed pathogen inactivation on convalescent plasma, but nobody really had data if this pathogen inactivation or also freezing or 4-degree storage does not impair the content of neutralizing antibody capacity. So we did a small study at that time point where we looked into the antibody capacity of these different, under these different conditions, and we found that storage as liquid plasma at 4 degree or cryopreservation to -30 degrees plus pathogen inactivation has no impact on the amount of IgG antibodies in total or the neutralizing antibody capacity, which you see here under B. We had been able to publish this in the journal Lancet Microbe early last year. I think it was May 2020. What we also looked at is, because we ended up having only a handful of donors with very nice high titer plasma, and because at that time point there were so many patients, we invited those donors for repeated plasmapheresis. So we were also looking, if possible, repeated apheresis has an impact on the amount of antibodies in these donors. And this is something which we could not observe. We see here the mean content of antibodies as either IgG or neutralizing antibody capacity. And we see that over the time point here of 15 apheresis, we see a small decline, but this is not indicative for the collection of the antibodies via plasmapheresis. This is more with regard to the decline over time after infection. At the later time point here of after like 8 plasmapheresis, you see it's only single digits single points because it was only 1 or 2 patients and we could not make any standard deviation anymore. So most of the patients here donated between 1 and 8 apheresis in total from our program. Now, what we do in Dresden now, especially after all these clinical trials, which showed that over all patients, convalescent plasma has no benefit, is that we looked into patients treated at the University Hospital in Dresden. And here we had a group of 14 patients which were severely immunocompromised. And in those 14 patients, when we looked for the change in WHO clinical progression scale, and this is only the data of change here, so the change, and we looked then into the IgG titer in the patients on day 5 after infusion of the convalescent plasma, we observe that patients which had more than 20 units per ml of SARS-CoV-2 antibody in the patient serum, that they all had very high reduction of 3 to 5 in the clinical scale. So these patients very much profited from the convalescent plasma, whereas those patients where we did not observe an antibody titer of above 20 after infusion, like those patients here, there is hardly any change in the clinical progression scale, or it gets worse. So everything which is above 0 here is not an improvement, it's a worsening over time in the patient according to the WHO progression scale. And we have been able to publish this as correspondence again in Lancet Microbe. It's out and will appear on March 30 online and is for everybody available. Another big topic, which perhaps, because I'm with a blood group background, of course, in transfusion medicine, which I'd briefly like to discuss, is the relationship between ABO blood group and COVID-19 susceptibility. There have been repeated reports of associations that showed that blood group A was associated with a higher risk for acquiring COVID-19 compared to blood groups which are non-A blood groups. And for blood group O, it was associated even with a lower risk for the infection compared to those with non-blood group, non-zero blood groups. And just briefly to look a little bit what could be behind all this, there's a very nice review and of data, also like a meta-analysis, association between blood type and COVID-19, infection, intubation, and death. And it was set for the individual blood group, always the risk for the blood group 0. Here you see on this scale, if it is 0, everything which is left is a lower risk benefit than for the other blood groups compared to 0. And for the intubation, it would be better for the blood groups. 0 is always set as 0 in this case. And if it is better, it goes on the left scale. If it's worse, it's on the right scale. And if you look at this one here, then you see that the prevalence of infection is bigger in, is worse in A compared to AB. And this is, I look only at the orange one, which is adjusted for different entities and ethical, not ethical, but ethnicities. And you see it's worth for A and B over a blood group O. And if you look at risk of intubation, you see that the blood group A and the blood group, blood group A, B, and B have a higher risk of intubation compared to blood group O. And if you look at death, you will see that the death rate is higher in the blood group AB, lower in A and B compared to blood group O. And this is just an indication here that there is a certain association apparently to the blood group A-B O system. If you look into the rhesus system, you see that in all cases, rhesus negative has a benefit, lower risk of prevalence, lower risk of intubation, lower risk of death compared to rhesus positive. But what could be behind this? And there was a whole genome analysis called Manhattan plot done over the entire chromosome set. And then it was looked for the log value, p-value, what is significant difference among those who have COVID-19 to those who have control group, which has no COVID-19. And there is basically two loci which are associated with COVID-19 severity of disease. And the one locus is in chromosome 3 and contains genes which encode for basically immune phenotypes and like ZXZR6 and also cytokine loci, CCR9. And the other one was on the chromosome 9, and here very prominent the locus for the ABO blood group. But of course, this doesn't show that there is a direct association. It only shows that there is basically an association, and it could be that there's other genes behind this which are located in the vicinity of ABO. And this is something, it's a German publication, goes back to 1994 by myself, together with my boss, Erhard Seifried at that time. And we looked into the factor VIII content in dependence of the ABO blood group. And what we see is that individuals with the blood group O have lower factor VIII concentrations in the serum or plasma compared to the A and B blood groups. And this also translates into the bleeding side as a bleeding time. So those with the blood group 0 have a higher and longer bleeding time compared to those who are non-blood group 0. And how does this correlate somehow with the blood group? Well, the factor VIII coagulation factor is associated with the von Willebrand factor antigen, and in turn, the von Willebrand factor antigen is carrying ABO blood group residues at the von Willebrand factor antigen, which apparently have an impact on the pharmacokinetics and the, or let's say the plasma concentration of the von Willebrand factor, and it's lower in blood group O compared to A and B, and then because the factor von Willebrand factor stabilizes factor VIII, you usually see also lower factor VIII levels in these individuals with longer bleeding times. If this may have an impact on the outcome, nobody knows, but as we see, there is a link between ABO blood group and coagulation, and as we today know also, there is links between coagulation and severity of coagulation as one of the side effects of a COVID-19, which also determines basically the outcome of a COVID-19 infection. Now, what do we do today in Dresden? The rationale for use of the COVID-19 convalescent plasma, we basically acknowledge that randomized clinical trials do not suggest a therapeutic benefit for COVID-19 convalescent plasma. On the other hand, immunocompromised patients with persistent COVID-19 infection may profit from high titer COVID-19 plasma, and certainly randomized clinical trials are pending and have to show this. But this in mind, and also the lack of any alternative treatment at these moments, what we do is in Dresden, patients who are immunocompromised due to stem cell transplantation or cancer, radiochemotherapy, or other causes, and who did not mount already a SARS-CoV-2 IgG response, are treated with high titer COVID-19 convalescent plasma. And what we are looking then is that we follow up on day 5 and use the 20 units anti-SARS-CoV-2 IgG titers then as a therapeutic guidance if the infusion may have been enough or not, or if another plasma will be needed in these patients. That's what we do. We observe this also, so we don't only infuse, but we also have a questionnaire, case report forms, and are looking into each and individual case with regard to the outcome due to the convalescent plasma. That's basically what we do, and there have been many people involved. I have to thank the entire group at the University Hospital in Dresden who set up this screening for patients, especially in the early phase where there were low prevalence rates and incidence rates still in Germany. It was very difficult to identify donors with high titer antibodies within our German Red Cross blood donation service. People in responsibility for the manufacturing, the donation, and the testing. Today we do the testing for SARS-CoV-2 antibodies ourselves. We have also test systems which allow very rapid results with regard to the neutralizing antibody capacity. But nevertheless, the gold standard still is the live virus assay, which is done in the Berlin Institute of Virology. So I have to thank everybody, and I'm open for questions.